Hello, internal medicine residents at Black Lion Hospital. Welcome to this brief lecture on vasculitis. My name is Dr. Paul Cauldron. I am a rheumatologist. I've been practicing rheumatology for about 38 years. Most of my practice years have been in the state of Arizona in the United States. I have teaching appointments at the University of Arizona College of Medicine, as well as Midwestern College of Medicine in internal medicine. So today I am going to give you a brief introduction to the area of vasculitis. Now, vasculitis is a lesser part of the practice of rheumatology. As you know, most of our time is spent dealing with rheumatoid arthritis, osteoarthritis, the spondyloarthropathies, and such more common disorders. Vasculitis is much rarer, but it's important because vasculitis can threaten lives and threaten organ systems. We need to be able to recognize it. We need to be able to classify it, and from that classification, on an individual patient basis, we need to map out therapy. So our learning objectives in this brief presentation will be to have you come away being able to identify the major types of vasculitis and associate them with the vessel type, the vessel size, to help with the diagnostic classification. And we'll begin to talk about the diagnostic approach to vasculitis. And lastly, we'll just briefly touch upon therapies. So what is vasculitis? We consider it a group of about 20 distinctive disorders that, as the name suggests, involve destructive inflammation in the walls of blood vessels. Now, both arteries and veins may be affected depending upon the clinical disorder, but the damage is mediated primarily by leukocyte migration into the vessel wall where the resultant damage takes place. It may be one of the true emergencies encountered in rheumatology, not an emergency like an acute MI or respiratory insufficiency, but since these disorders may threaten organ system integrity and eventually threaten lifespan, they're considered very important and some of the more emergent reasons for our intervention. Now, we're going to spend some time on this slide because in the conditions of vasculitis, this slide sort of tells the whole story. So if you don't concentrate on anything else, concentrate on this. The vessel size is the basis of classification of vasculitic disorders. The second level of classification has to do with individual clinical presentations. So I'm going to walk you through this very carefully, and we'll spend some time on it. So think about vasculitis first in terms of vessel size: large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. In the category of large vessel vasculitis, we're mainly talking about two disorders: giant cell arteritis, also known as temporal arteritis, and Takayasu's arteritis. These involve the aorta and major branches, first and second generation branches off the aorta, mainly the aorta itself and first order branches off the aorta. Medium vessel vasculitis involves muscular arteries of second and third and other generations of muscular arteries. And these disorders can be divided into those that are immune complex mediated. That means that there's something in the blood that we created antibodies to, and we're generating immune complexes that deposit it in the walls of the arteries. The main example of that is polyarteritis nodosa, and we can see a similar problem in patients with advancing uncontrolled rheumatoid arthritis. The second category of medium vessel vasculitis are those disorders where there are anti-endothelial cell antibodies. That means the internal elastic lamina is being attacked by antibodies. The most common sort that we've seen is called Kawasaki's disease, mainly a disorder of children, babies and children, but we can see it in adults occasionally. And now with the advance of COVID-19, we have seen cases that look very, very similar to Kawasaki's disease provoked by COVID-19. And lastly, small vessel vasculitis. This is the most, perhaps the largest group of disorders of vasculitis, and they can be divided mainly along two lines as well. The vessel size are the arterioles, small and including non-muscular arterioles, the capillary bed, and some venules. And the main two categories are those that are not associated with immune complexes, called pauci-immune. There's a paucity of immune complexes, meaning you don't see a lot of deposition of immune complexes in the walls of the vessels. This is often associated with a set of autoantibodies called anti-neutrophil cytoplasmic antibodies, and we'll spend a little bit of time talking about those. Among these disorders are three principal ones. Possibly the most common is one called granulomatosis with polyangiitis. It used to be called Wegener's granulomatosis, and some people still default to that name. You see granulomas in the walls of the arteries, but you don't see a lot of immune complexes deposited. It is not associated with asthma. It has a much rarer cousin that is associated with an asthmatic and eosinophilic presentation. But otherwise, there's similar granulomatosis within the walls of the arteries. It's called eosinophilic granulomatosis with polyangiitis. It used to go by the name Churg-Strauss syndrome, and a lot of people of my age still default back to that name. So think about an asthmatic presentation with other histologic features of GPA. The last category, and this is not rare, is called microscopic polyangiitis. It is a vasculitis without asthma or granulomas within the walls. But all of these, including microscopic polyangiitis and Churg-Strauss, are also associated with ANCA antibodies. Wegener's, or GPA, has the strongest association with ANCA, as we'll review in just a moment. The other category of small vessel vasculitis is associated with immune complex deposition. And perhaps the most common of those is that associated with lupus. We'll see a small vessel vasculitis involving skin, possibly kidney, and other tissues that is associated with immune complex deposition on tissue analysis. Other types involve an IgA-mediated type of small vessel vasculitis. We often refer to this as Henoch-Schönlein purpura, or HSP. That associated with cryoglobulins for whatever reason as the basis of the vasculitis, as the basis of the immune complex, and other rare disorders such as Goodpasture's disease, where we have immune complex deposition in lung and kidney, provoking a small vessel vasculitis that's quite damaging. So Vessel size, large vessel vasculitis, medium vessel vasculitis, small vessel vasculitis, and we'll next talk about the individual categories of clinical presentations associated with vessel size. So this slide is the second most important slide to help get into your head an organization of the vasculitic disorders. So as I mentioned, large vessel vasculitis includes the aorta and the great vessels, mainly the first generation muscular arteries off the aorta. Medium-sized vessels, the second and further generations of arteries with a muscular wall, and the small vessels, capillaries, arterioles, venules. Now, when the large vessels are involved as the primary syndrome, we see claudication. There's a distinct disorder called Takayasu's that tends to occur in young, mostly Asian women, and they present with a chronic illness with constitutional symptoms, and the hallmarks are having claudicatory symptoms in upper and lower extremities, and on exam, pulselessness. That's Takayasu's arteritis, one of the two main types of large vessel vasculitis. The blindness and strokes are associated more with what we used to refer to commonly as temporal arteritis. Now we refer to it more as giant cell arteritis. And these are older people, generally Caucasian, who present with headaches, acute visual loss, jaw and swallowing claudication, pain in the jaw and pain in the neck and tongue as they chew and swallow. And they may have scalp tenderness. So we see symptoms associated with the major branches off the aortic arch. And that's temporal arteritis or giant cell arteritis. So giant cell arteritis, temporal arteritis, we talked about Takayasu's in young, mostly Asian women presenting with claudication. Behçet's disorder and Cogan's syndrome are more rare. We'll talk about Behçet's in another setting. Cogan's syndrome seems to be a rare form of vasculitis that mostly involves auditory function and visual function, and that's much rarer and can be covered elsewhere. Think about large vessel vasculitis as mainly giant cell arteritis and Takayasu's arteritis. Now, with the medium vessels, when they're affected, the presenting calling cards are mononeuritis multiplex, meaning wrist drop, foot drop. And this usually occurs rather suddenly. Basically overnight, over a day or two, person develops a perineal palsy or a radial palsy, a foot drop, or wrist drop. Or they may present with mesenteric ischemia, such as abdominal claudication. Within an hour after eating, they get abdominal pain that will persist for perhaps several hours and dissipate, only to come back after another meal. So when you see somebody presenting with abdominal claudication, think about a medium vessel vasculitis. And we can also see cutaneous ulcers. And these are fairly thick. They go through the thickness of the skin. They're not just superficial like purpura. They are lesions that progress deeply and result in ulcers. So that's what we see when medium vessels are inflamed. Now, when we see small vessels inflamed, let me go back to medium vessel. The principal diseases, as I mentioned before, the classic one is polyarteritis nodosa, in which the presenting symptoms are usually cutaneous ulcers, mononeuritis multiplex with foot drop or wrist drop, and sometimes abdominal claudication. We can see a form of vasculitis in the central nervous system, what we used to call primary angiitis of the central nervous system. And this can present with headaches and strokes and on imaging looks like a vascular mass. This is much rarer, but sometimes will occur in the absence of mononeuritis multiplex or other abdominal or skin findings. Kawasaki's disease, as we mentioned, is in this category. And there are two outliers that are not rare. Berger's disease, which is in a different color, as is rheumatoid vasculitis, because these are not primary vascular disorders. Berger's is strongly associated with smoking tobacco and deserves its own lecture. We'll talk about that at some time. Rheumatoid vasculitis, as I mentioned, rheumatoid arthritis in advanced state, an aggressive state, can present with a classic mononeuritis multiplex with mesenteric ischemia and cutaneous ulcers in someone who's had long-standing rheumatoid arthritis. So rather than being a primary vasculitis, this is a secondary form of medium vessel vasculitis. Now, in small vessel vasculitis, the things that patients present with will be palpable purpura, and we'll see some pictures of that, glomerulonephritis, and pulmonary hemorrhage. These are the calling cards of small vessel vasculitis, and the typical disorders are going to be, as we mentioned in the previous slide, granulomatosis with polyangiitis, microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, and one associated with IgA immune complex, Henoch-Schönlein purpura. Now, again, cryoglobulonemic vasculitis is secondary to some other disorder, maybe hepatitis C, hepatitis B, where we see cryoglobulin formation, and that's the essence of the immune complexes that are promoting this small vessel vasculitis. But if you can remember, these pauci-immune, and that means not having an association with immune complexes, and HSP that's associated with IgA-mediated immune complexes, then you'll have a sense of the primary small vessel vasculitides. Now, having gone through the clinical classification, the diagnostic classification of the primary vasculitic syndromes, let's now talk a little bit more about the secondary vasculitic syndromes. We've already touched on some of these a little bit, like rheumatoid vasculitis, which mimics the primary polyarteritis nodosa. We've talked about other diseases such as cryoglobulonemic vasculitis and lupus vasculitis that can present with immune complex small vessel vasculitis. So now these are the major classifications of secondary vasculitis. Drug-induced vasculitis, there's a whole list of drugs that may cause people to form immune complexes, and as those immune complexes deposit in vessel walls, the predominant areas of deposition are going to be in the small arterioles and capillaries and venules, so we'll see a presentation that is small vessel vasculitis. Serum sickness. This is an old classification that comes from when people used to get horse serum or any sort of serum taken from another organism, and we might see that associated with blood transfusions, and we might see it associated in the COVID-19 era when people are giving their serum with antibodies to patients with COVID to try to combat that infectious disease. But those immune complexes that can form can cause a vasculitis called serum sickness. Now, so we mentioned there's vasculitis associated with other primary diseases such as lupus and rheumatoid arthritis. Infections can often provoke high titers of circulating immune complexes and result in a secondary vasculitic syndrome. Malignancies can do the same, mainly through immune complex mediated vasculitis, and as we talked about, rheumatoid arthritis can do the same. So we reviewed the primary vasculitides, and we talked about secondary forms of vasculitis, secondary to other diseases. And now there's a category that some people like to refer to as mimics, those disorders that are not truly vasculitis, primarily or secondarily, but give clinical features and signs that might suggest vasculitis. Among those are infectious diseases, usually endocarditis and HIV. Will present with mucocutaneous findings that can look like vasculitis, but are not. And may have to do with infectious emboli or other types of cutaneous, mucocutaneous lesions that look like purpura. Drugs, the main being cocaine and methamphetamines. This has to do with things that can happen in the skin, mucous membranes, muscles, joints, other organ systems as a vascular response to these agents. Cholesterol emboli, particularly in the setting of long bone fractures, where cholesterol emboli are released and may go to lungs, brain, kidneys, other tissues, and mimic some of the findings of vasculitis. So keep long bone fractures in mind, principally. There's a few other sources, but that is the main one to keep in mind. Antiphospholipid antibody syndrome is another. This is a primary syndrome that involves a coagulopathy, clotting forming in any size artery or vein, certainly can produce multi-organ system effects that can mimic the clinical presentation, signs and symptoms of vasculitic disorders. And lastly, benign angiitis of the CNS, also referred to as reversible cerebral vasoconstriction syndrome, BACNS or RCVS. This is a benign vasospastic, angiospastic syndrome that can generally present with headache, a particular type of severe, sudden, what they call a thunderclap headache. And it's reversible. It can look like vasculitis on angiogram, but as the vessel walls relax, it goes back to normal and the symptoms subside. But this can mimic, in some people, the primary angiitis of the CNS, which, as we know, is a medium vessel type vasculitis that, for reasons we don't fully understand, may be isolated to the cerebral vasculature. So this slide is about common clinical manifestations of vasculitis. And as you look through this busy slide with all these things on the list, you realize that there are no exactly specific symptoms that tell you, oh, this symptom, this finding must be vasculitis, because you know when you read through each of these that they can occur for many reasons. So this is sort of looking at the subject of vasculitis in reverse. When you see someone come in with constitutional symptoms, fever, sweats, weight loss, you know the diagnostic list is long. But in that list, somewhere on down, after you've ruled out many, many other things, you need to think about primary vasculitis and or secondary vasculitis. All these things that we can see in the skin can occur for a number of reasons. Somewhere in the list should be primary vasculitis. And I'm not going to go through all this, but spend a little time on this slide when you get the chance and think about it. Ocular findings, renal findings, genitourinary findings, all of them can be parts of one or another of these primary vasculitic syndromes. Okay, now we've reviewed the classification of primary and secondary vasculitis based upon vessel size and clinical presentations. And we've talked about some other clinical syndromes that can mimic a lot of the features of vasculitis. And we've talked about the array of multi-system, multi-organ system presenting findings for which vasculitis should be within the differential diagnosis. Now, how do we get to a diagnosis? This could be a whole lecture in itself and an exhaustive lecture. We're just going to touch the surface. The diagnosis of the systemic vasculitides are a diagnosis of exclusion. So you really have to say, when patients present with these findings, what's the likelihood of an infection, and go down that pathway. If that's not yielding something, is there a malignancy? Is there another primary autoimmune disease like lupus, like rheumatoid arthritis, something like that, of which these findings may be attributable to? Is there a malignancy that may be mimicking vasculitis? So once you go through your differential, think about vasculitis as a diagnosis of exclusion. And then you take the next step by looking at the whole of the clinical presentation. You know, you have to use your internal medicine brain to actually do sort of an inventory of organ systems. You know, which organ systems are sick in this patient, and how are they sick, in what way? And you do a mini differential of each organ system. And if they each point away from infection, malignancy, drug-induced, thrombotic-induced, point away from that, that's when you're moving towards a diagnosis of vasculitis. For example, eosinophilic granulomatosis with polyangiitis. Think about what we think about it when we see an adult who has had the onset of asthma newly within the past couple of years. Mostly the onset of asthma is in childhood, but when it's later in adulthood, we have to consider this as atypical and think about whether it may be EGPA. Often the onset of asthma is followed by episodes, perhaps hospitalized episodes, that look like atypical pneumonias. And then we start to see peripheral nerve involvement, like a foot drop or wrist drop, and we might see palpable purpura as evidence of small vessel vasculitis in the skin. So, you know, oftentimes it takes a long time to make a diagnosis of vasculitis, and over time you've ruled out a lot of other things, and then it becomes apparent clinically. Now, the most direct evidence for vasculitis is, of course, a tissue sample. Biopsy of involved organ is the most straightforward method of establishing a diagnosis. And it also may be helpful to eliminate infection or malignancy. All of our other tests, which we mentioned, may be suggestive but not diagnostic. In the blood, we'll see that autoantibodies called ANCA, anti-neutrophil cytoplasmic antibodies, are the strongest antibody tests associated specifically with vasculitis. But even though they are the strongest, they're certainly not diagnostic. Most people with ANCA antibodies do not have an ANCA-associated vasculitis, but something else. But if the diagnostic tree that we've gone down has eliminated most of the other potential causes for the patient's presentation, and they come back with significant titers of ANCA, that should boost our suspicion of a small vessel vasculitis. Obviously, as I mentioned, whenever we do our internal medicine diagnosis, we kind of do a mental inventory of each organ system in the patient in front of us. And we do the other simple tests. We do other blood analysis, we do urinalysis, we do basic imaging, and we might do some scopes. And scopes can tell us something by visualization, and certainly by the access to tissue for biopsy. So let's take a few more minutes to talk about anti-neutrophil cytoplasmic antibodies. When I was in training, these were not available. And as they came available, we found them to be the most strongly associated autoantibodies with disease states that are available to us. So these are autoantibodies. They are antibodies against myeloperoxidase, called MPO ANCA or p-ANCA, and against a protein, an enzyme called proteinase 3, PR3 ANCA or c-ANCA. So think about these names as being interchangeable. MPO or p-ANCA and PR3 or c-ANCA. None of these are 100% specific or sensitive, but they can still be very useful. So this table is complex, but we can make general associations that are stronger or weaker. So with the p-ANCA antibodies, think about the primary vascular disease include microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, and polyarteritis nodosa. Other diseases which we can see with p-ANCA are collagenoses, Felty syndrome, rheumatoid arthritis, SLE, Sjogren's syndrome, sometimes chronic inflammatory bowel disease, sometimes chronic liver disease such as primary sclerosing cholangitis. There is a strong association of c-ANCA, mainly with GPA overall. And the atypical ANCAs, those that are either not p-ANCA or c-ANCA or a mix, we can see associated with primary sclerosing cholangitis, primary biliary cirrhosis, autoimmune hepatitis, lupus, and rheumatoid arthritis. So if you're confused, that's good, because I want you to go away with the feeling that whereas these antibodies can be associated with particular types of vasculitis, they are not diagnostic and they can occur in other inflammatory syndromes involving other organ systems. So this is another complex slide, but I use it to drive home that point. I want you to look at ANCA antibodies. Let's talk specifically first about the PR3 or c-ANCA and this association. In granulomatosis with polyangiitis, also known as Wegener's disease, you have an 85% positivity rate. So that is about the strongest association of a disease with an antibody as you'll ever find. But even with GPA, 10% may also, or apart from c-ANCA, have MPO ANCA or p-ANCA. And about 5% will be ANCA negative altogether. Okay? Now, with microscopic polyangiitis, about 50% are MPO positive. So this is a fairly strong correlation. But then again, the other 50%, some will have c-ANCA and some will be entirely negative. So you make the diagnosis not based solely upon the autoantibody that's present or the subtype of autoantibody, but on the clinical presentation and perhaps the tissue biopsy. With eosinophilic granulomatosis with polyangiitis, about 60% are going to be p-ANCA positive, about 10% c-ANCA positive, and about 30% will have neither. So this just is a little bit of a guide of epidemiologic relationship with these ANCA subtypes. So the major point is look at the clinical features of these disorders as they present, and secondarily look at the, whether ANCA is present and what type of ANCA. And that may shore up your diagnostic confidence. So how do we get to a diagnosis of vasculitis or the differentiation of vasculitis among different types and apart from other disorders? Well, you know as internists that you start with your organ system inventory. You get your chemistry panel, you get your complete blood count, you get your urinalysis. You'll probably want to get a chest x-ray in almost any syndrome that makes you think of vasculitis. And you'll get an ANCA test. So beyond those, there are lots of tests that we get, but most of them are non-specific. And to arrive at a satisfying diagnosis, we'll take all those pieces of information, aggregated and analyzed to make your assessment. There are a whole bunch of markers of inflammation that are entirely non-specific and can be abnormal in vasculitic syndromes as well as everything that mimics vasculitis, such as your SED rate, your C-reactive protein, leukocytosis, thrombocytosis, anemia, low albumin, low serum proteins. All of these are completely non-specific and can be seen in any type of inflammatory condition. There are some tests that help us look at other diagnoses that may be driving the vasculitic syndrome or mimicking it, such as hepatitis B surface antigen, hepatitis C, complements to see if they're being consumed, as we might see in lupus, that might be driving a small vessel vasculitis with glomerulonephritis. HIV, as I mentioned. If there are any other features or history in someone that you suspect vasculitis, check their HIV status. You may check their ANA status, extractable nuclear antigens, looking for clues to other autoimmune disorders that may be underlying a presentation of small vessel vasculitis with palpable purpura, coughing up blood, blood in the urine, signs of glomerulonephritis. It's worthwhile to check all of these routinely when you're suspicious of vasculitis. Imaging studies come next. As we've talked about, there are disorders such as the small vessel vasculitis, granulomatosis, GPA, microscopic polyangiitis, eosinophilic fasciitis, eosinophilic granulomatosis with polyangiitis, EGPA, where you're going to want to look at the respiratory tract, the upper respiratory tract, the lower respiratory tract. MRA, magnetic resonance angiography, is very useful as a non-invasive way to look at vessel anatomy. And then there's classic angiography, contrast angiography. Even angiography is non-specific in vasculitis. You get the impression of large and medium vessel vasculitis if you see occlusions where there is a tapering of the vessel wall rather than a straight cutoff or a beaded appearance. A straight cutoff suggests a blockage from a clot or an atherosclerotic plaque that is ruptured and thrombosed, or if you see a beaded appearance, which is not in this picture, that may make you think of fibromuscular dysplasia of the arteries or atherosclerosis. When you see narrowings that are led up to by a tapered vessel wall, that makes you think of vasculitis. And lastly, and all important, is biopsy. And some biopsies are more directive than others. We specifically do temporal artery biopsies in people that we suspect giant cell arteritis, in older people presenting with visual changes, headaches, jaw and swallowing claudication, and scalp tenderness. Biopsy is not perfect. You need to get a long specimen of biopsy, and we can come back and talk about that when we talk about these individual presentations. A temporal artery biopsy is very useful. Sural nerve is an easily accessible tissue to biopsy, along with the muscle biopsy. These two often go together to find small and medium-sized muscular arteries and examine them for evidence of inflammation. Obviously, vascular tissues such as lung, kidney, brain, and skin are open to biopsy. Brain biopsy is usually a small hole in the occiput where you take out a little piece of leptomeningeal tissue, which is highly vascular, and look for evidence of central vasculitis. So really, the gold standard in confirming the diagnosis of vasculitis is biopsy. Do we do it always? Not necessarily. When a patient is compromised and not available for a biopsy, or if the diagnosis is overwhelmingly clear, supported by, say, ANCA and the classical presentations, one may choose on an individual biopsy, on an individual basis, not to pursue a biopsy. And that will be dependent upon your clinical circumstances. But in general, tissue biopsy is highly desirable when you move very close to confirming a vasculitis diagnosis. So as we move to a brief discussion of treatment, I just want to emphasize that I look forward to having the opportunity to discuss individual cases that present to you, that you want to present to me, to make the differential. And if we are clear and confident in a vasculitis diagnosis, then we can go into more of the individual application of treatments depending upon that patient's circumstances and needs. But in general, the division of the treatment of vasculitis is, again, we think about ANCA-associated vasculitis, the C-ANCA and P-ANCA type of vasculitis, small vessel vasculitis, the GPA, MPA, EGPA. There is a treatment algorithm that is fairly standard. It begins with corticosteroids because corticosteroids work fastest in inflammation, but they also have potentially the worst side effects over time. So we want to move to something that is immune modulating and effective, shown to be effective in these types of vasculitis. And we have two big options. One is rituximab, which is an anti-B cell biologic infusible agent, or cyclophosphamide, an old-time chemotherapeutic agent, which is more often available in countries in situations where rituximab is not available. There is some suggestion that trimethoprim sulfamethoxazole may have some therapeutic effect in ANCA-associated vasculitis. This is controversial. It's not well confirmed, but often people will add trimethoprim sulfamethoxazole to these therapies early on with caution. So when we've gotten to, a remission with this induction therapy, then we may maintain with periodic use of rituximab and with other anti-metabolite agents, anti-metabolic agents, methotrexate, azathioprine, mycophenolate, and leflunomide. So applied individually, depending upon the clinical circumstances, what resources are available, can guide our initial choices for remission maintenance. Now, in non-ANCA-associated vasculitis, and what's that going to be? That's going to be our temporal arteritis, it's going to be our Takayasu's arteritis, it's going to be HSP, it's going to be lupus-associated vasculitis, perhaps rheumatoid-associated vasculitis. Sometimes we use prednisone as monotherapy. More often, we use this, again, to induce a control of the manifestations of the vasculitis, and then we add on other antimetabolites such as methotrexate, azathioprine, myclophenolate, or leflunomide to the remission control paradigm for treating. Tocilizumab has been shown to be somewhat effective in giant cell arteritis, and this is an infusible biologic against interleukin-6, an IL-6 antagonist. And it has been shown to be helpful in some patients with temporal arteritis, giant cell arteritis, in limiting the amount of corticosteroids that are needed for the long term. And that may be very important. So I don't want you to get buried in the weeds of treatment right now. When we have a case to discuss, we can get into the weeds and talk about options, what's available, what are our best choices, how to monitor therapy, both for induction and for long-term maintenance. So maintenance involves follow-up at least every 3 to 6 months. And when we're first getting a patient into remission, obviously we're going to want to see them every week or every couple of weeks till they're doing much better. Obviously need to monitor for drug toxicity and for disease activity with our CBCs, chemistry panels, acute phase reactants, and urinalysis. So I'm going to close it off there. 2 important sources that you might do. I know you guys have access to UpToDate. There's a good overview of vasculitis and the approach to vasculitis in adults by a guy named Peter Merkel. Very smart man, and I think you'll enjoy this. It'll hopefully reflect this brief lecture that I've given, and you'll find it useful. Another deeper dive would be to go to the website of the American College of Rheumatology, the ACR, and look for their endorsed study of the diagnostic and classification criteria for vasculitis. This is highly detailed, and if you are seeing a number of cases of vasculitis and you really want to get deep so that this anchors into your psyche, this would be a very good reference for you. So once again, I look forward to discussing cases and driving this differential in how we approach patients with vasculitis when we see your cases. Thanks very much.